And so the topic today is going to be West Nile virus infection. A few disclosures. I do receive funding mainly through the help of my colleagues directly in this room, particularly Sharon Sims, with the Arbovirus research grants from the Corey Foundation here in Washington, D.C., Wilson Research Foundation, part of Methodist Rehabilitation Center, and the Mosquito Illness Alliance. So what is West Nile virus? It's an arthropod virus that can cause inflammation and infection of spinal cord and brain. It actually attacks the central nervous system. The family of viruses is the flavivirus, or yellow flavy, and it has a number of very famous or infamous viruses, including dengue, which is extremely common south of our border. And last year it infected approximately 100 million people. These are individuals who actually had a clinical infection. Zika virus, I think we all know about Zika and the media blitz that occurred about a year and a half ago. Yellow fever virus, a notorious virus that actually prompted the development of the yellow fever vaccine in order to control the area of the Panama Canal. And the vaccine was actually available for this particular virus in about 1932. Yes?
Excuse me for 1 second. We need to figure out why people are not hearing.
Oh. Testing. Okay. And so the West Nile virus is, and all these flaviviruses are single-stranded RNA viruses.
Okay, and the virus is transmitted to humans by mosquitoes, although other forms of transmission are possible, but typically not through direct contact. The first case of West Nile virus was from a woman in the West Nile region of Uganda, Africa, in 1937. In the 1940s, it was determined that transmission was by mosquitoes, and there was a very close antigenic relationship with SLE and the Japanese encephalitis viruses. These are also flaviviruses. And neutralizing antibody was found in residents of East and Central Africa. The neutralizing antibody is defined as IgM or IgG, and it is what confers immunity after exposure to the virus. It's also how we diagnose the infection. In the 1950s and through 1970s, it was found that birds were the major reservoir host. Horses were commonly infected. There were large epidemics in Africa and the Middle East. And the first case of West Nile was reported in Europe. There have been a number of notable West Nile outbreaks, but the Romanian epidemic in 1996 marked the transition from urban industrialized areas, from actually rural areas to more urban industrialized areas. And there was also a change in the neuroinvasiveness of the virus. There are more cases of meningitis and encephalitis. From that point on, all the major outbreaks have centered around major metropolitan areas. The virus gained entry into North America in the New York City outbreak in 1999. There were hundreds of native and exotic birds. I once talked to an individual who worked at the zoo, and they lost over half of all their bird species. There were dozens of horses that were infected. There were 59 humans that were hospitalized, and 7 human deaths. The deaths were interestingly attributed to a paralyzing illness and the encephalitis. But the encephalitis as I'll show you later, the encephalitis in West Nile virus infection is not a severe encephalitis. In fact, on the postmortem, the autopsy cases in these 7 humans, all 7 brains were normal to inspection. So if you looked at the brain, you couldn't tell that there actually had been pathology. So the encephalitis, again, is a relatively benign encephalitis, which is why there are many of you in this room who actually had the encephalitis and are here to listen and to communicate with what has happened to you since that time. I'll show you some slides of other encephalitides where the outcome is much, much poorer. So the possible pathways of introduction, an infected human host is very, very unlikely. In fact, the chances are almost nil that this was a possibility. And the reason is that the viremic phase, which is the phase in which the virus actually circulates in the bloodstream in humans, is a very, very short phase. It's usually measured in hours, and the viral load is extremely low. To give you an idea, in the bird, which is the host in nature, the viral load is 10 billion-fold greater. And the viremic phase in birds is measured in days or weeks. It may have been through a mechanism of transporting birds legally or illegally. That's quite possible. Migratory birds is also a possibility. Or human-transported mosquitoes. It's very easy to speculate that mosquitoes were trapped in Israel, where we think the virus originated from, trapped and crated, and the crates were opened in New York City. So, how is it spread in nature? This is primarily a bird-mosquito cycle. You have the bird as the principal host, and the vector is the female mosquito. The male mosquitoes are not the problem. They don't bite humans as far as we know. But the female needs a blood meal in order to have the development of the eggs. And so it's the female who's actually doing the spreading the disease, and that's true in other flaviviruses. We are considered dead-end hosts because of the reasons I mentioned, our very short viremic phase and the very low titers of viruses in our bloodstream. There are new modes of transmission since 2002, blood products, but now in the United States, blood donors are routinely screened for the virus. Organ transplants, there are a number of reported cases through kidney, liver, heart, lung transplants, and that's understandable. Transplacental mother to fetus is actually the rule, not the exception in most viruses. Breastfeeding also can cause spread of the infection. And percutaneous, meaning that a worker accidentally takes blood from a dying blue jay and accidentally sticks his hand, and we can understand why that would be not uncommon. And dialysis related, there was a report, I think 2 reports of cases where the equipment was just not sterilized properly and went to another patient. This is 1999, again, the entry into New York City. In 2000, in 2001, and 2002 was a nationwide epidemic. There were thousands of cases of West Nile virus infection, and there were hundreds of cases of neuroinvasive disease. In 2010, the approximate geographic range involved 6 out of 7 continents, with Antarctica being the only exception. Now, I want to talk a little bit about what happens after the bite, because the incubation period is defined as the time from the bite to the onset of disease symptoms. And that typically, the range is anywhere from 2 to 15 days, but in general, it's going to be closer to about 4 to 10 days in most individuals. And the bite itself is actually quite interesting. Again, it's only the adult female mosquitoes, but the saliva is what transmits the actual virus. And the saliva contains a bunch of proteins and enzymes, lysozymes, glucosidases that actually start breaking down cell walls and dissolving sugars, anticoagulants, and antiplatelet factors, so that when a mosquito bites, the blood cannot clot. It will keep on flowing because it can no longer clot because of the anticoagulants, and vasodilators. So not only can the blood not clot, there are chemicals in the saliva that will actually allow the arteries to expand so that more blood goes to the site while they are feeding. Now, the allergens can induce a local skin reaction, as we all know, is itching, scratching, and that attracts inflammatory cells and causes histamine release, which then causes more itching, and the cycle perpetuates, eventually leading to the red bump that's the hallmark of a mosquito bite. Now, what we didn't know, but now there's evidence that this type of scratching actually facilitates the spread of the infection. The major reason is that when you scratch, you increase the histamine, you bring in the immune cells, and it's the immune cells that actually cause the virus to spread through lymphatics into bloodstream. So don't scratch. So I was touching the internet, and the internet can be a great source of information or not. And so I have to just read this one. I just laughed. Why do mosquito bites itch? When a mosquito bites, it mixes in the blood of previous victims. Sheep DNA, deoxyribonucleic acid, makes our blood unusually woolly, which causes the bites to itch. There were others applying mud to mosquito bites. In fact, there were probably several hundred pages on home remedies. Literally everything. You can throw the whole kitchen sink at it, and it will be to some degree used by some people to take the itch off of the mosquito bites. In general, what works is the 3 Ps. The protective clothing is preventive. Pruritus is the medical term for itching or an itching rash, to control the rash, and patience. Treatment of the bite, if you need symptomatic treatment, then topical steroids or antihistamines, topical like Benadryl cream or diphenhydramine cream will actually also work. So after the bite, so the bite is into the skin. Infection begins in skin cells. These are the keratinocytes, which are just the skin cells, and immune cells. These are called Langerhans or dendritic cells. They're the ones that actually are supposed to take the virus or supposed to take the bacteria and then present the bacteria and the virus to be gobbled up by other immune cells. The problem with West Nile virus is that it actually enters into these cells. And so it's actually not destroyed and not presented while inside the cell, and then the cells actually go through the lymphatic system, lymph nodes here, and then eventually spread to the bloodstream, and that starts the viremic phase. We think that the West Nile fever, which is the onset of the clinical symptoms of fever, chills, I'll show you a slide in just a moment, actually begins in this particular phase while the virus is freely flowing throughout the bloodstream. But it also disseminates into a number of organs, spleen, kidneys, and liver, and can go to other organs. At this point, it is not actually it's not neuroinvasive, it's not actually invading the spinal cord or the brain. And that's what you need for it to become neuroinvasive. So CDC likes classifications. And so this was the more recent classification. I abridged it a little bit, but West Nile fever was described as a relatively mild, self-limiting infection, sometimes in the past referred to as a summer flu. And by definition, the neuroinvasion does not occur in these fever cases. West Nile meningitis is considered the milder neuroinvasive form. There is white cells, immune cells in the spinal fluid, and the changes in consciousness are relatively mild. West Nile encephalitis is a severe form of the neuroinvasive disease. you have altered consciousness, confusion, coma, focal neurological deficits, and in 5 to 15% of the cases, it can lead to death, along with this condition known as West Nile acute flaccid paralysis. And this is identical to the poliovirus, poliomyelitis. If we look at the clinical and if we look at the histology, we cannot tell the difference because it damages the motor neurons in the spinal cord and the same areas in the brain that are damaged by that were damaged by the poliovirus in the epidemics of the 1940s and 1950s and early 60s. And this can progress to respiratory paralysis. It may present as an isolated limb paralysis and can occur without fever or apparent viral prodrome. In fact, it can occur without any fever, chills, nausea, vomiting, headache, or any other symptoms that you're infected. And so there was a West Nile virus human pyramid, and this was based on reported cases. And this is from 2012, the most epidemic year, along with 2002. And roughly 80% of cases are asymptomatic. That means the mosquito deposits the virus into your bloodstream. You build antibodies to the virus, which your immune system shuts it down before it causes any clinical symptoms. And again, that's the majority. That's about 80% of the cases. For comparison, the poliovirus, about 90% of the poliovirus cases in the 1940s and 50s were actually asymptomatic. The difference is that the route of transmission was very different. In poliovirus cases, there were millions of Americans who were affected on a given outbreak, and then the remaining 10% would develop this paralytic syndrome. But sometimes, depending on the year, that led to tens of thousands of paralyzed cases. And so in terms of the neuroinvasive disease here, it usually makes up about half of the cases, and the fever cases make up the other half on any given year. We think that the exposure to the virus and the production of what we call IgG antibody will generate a lifelong immunity. I'll talk more about that later. So, fever symptoms, again, summer flu, fever, chills, headaches. It truly is a lot like a summer flu. Muscle aches and pains. You can have GI symptoms, anything from diarrhea to constipation. There may be a rash in a minority of cases, and swollen lymph nodes. The neuroinvasive disease is typically characterized by higher fever, worsening headache, confusion, muscle weakness, paralysis, ataxia, which is a problem, and disruption of the rate and range of the control of movement, tremors, seizures, a dysautonomia, which I'm going to address later because it's a not uncommon consequence of this type of infection, but unfortunately almost unrecognized symptom, and other focal symptoms can occur. And that results in the acute flaccid paralysis, which is the poliomyelitis type of presentation, respiratory distress, stupor, coma, and in 5 to 15% death. So how does the West Nile virus escape from the bloodstream to the brain or spinal cord? And it does so through direct, we think it can actually attack the lining of the arteries and veins and go directly through the lining and affect those what we call endothelial lining cells. And once it gains entry, it can then go through the cell and into brain or spinal cord tissue. But there's also a mechanism through these what we call cytokines. These are inflammatory chemicals, and when there is a release of these vasoactive chemicals, you have disruption of the blood-brain barrier. The blood-brain barrier typically will prevent all cells from getting through. But what happens with these chemicals is that you have openings in the blood-brain barrier, and the virus can then enter into the central nervous system. There's a Trojan horse mechanism which has been popularized by our colleague, Dr. Bai at University of Southern Mississippi. He's the only researcher in Mississippi at this point that can actually handle the live virus. And he and his team wrote a paper recently on the Trojan horse mechanism. And what they showed is that the virus actually enters, if you see here in this particular diagram, it enters these immune cells, and instead of being destroyed, it actually seeps through this blood-brain barrier, and this is so-called, hence it's called the Trojan horse. They actually hide within the cells that are supposed to protect us from that type of invasion. And then they start targeting these astrocytes and then the actual neurons. And the final mechanism is there's some thoughts that the virus actually starts in the nerves. So if a mosquito bites me in the hand, the virus will flow into the median nerve, which is the carpal tunnel syndrome nerve, and then it will flow up and enter my spinal cord, and then from the spinal cord it will be circulated into spinal fluid, and then it can gain access to the brain. So the meningitis is clinically similar to other viral meningitis. This lining, it affects only the lining of the brain. This is actually not a case of West Nile meningitis. You wouldn't see all these hemorrhages. But in this condition, only the lining around the brain and spinal cord are actually invaded and affected. You have fever, headache, lethargy, nausea, vomiting, dehydration, and something called meningismus, which is called also nuchal rigidity. And one of the clues is if the patient's lying down, and you attempt to bring the head up, it won't be, the head won't come up. It's not going to be that loose or flaccid, and it causes severe pain. And that's called nuchal rigidity or meningismus. It is a sign of meningitis. And then the photophobia, which is you don't like bright lights to be flashing in your eyes while you have this condition. You have white cells, immune cells in the spinal fluid. There's a battle going on between your immune system and the invading organisms, and the prognosis is usually favorable because it doesn't really penetrate the brain. In encephalitis, it does penetrate the brain, and that's why you have the weakness on one side of the body, difficulty, for example, understanding the written or spoken language. You may have difficulty expressing the language. There may be a number of different movement disorders, everything from tremor to more gross movement disorders, and you might also have seizures. The severity ranges from confusion to coma, and we talked about the fatality. But the fatality is clearly higher in the elderly and the immunocompromised. I remember a case, a young lady from, I think she was from Nebraska, and she came to us in a wheelchair, and she was only in her upper 20s, but she was also a myasthenia gravis patient. And so she had been on high-dose steroids and a drug called methotrexate. And so both of those are immunosuppressive agents. And so she was immunocompromised because of the myasthenia gravis treatment that was being initiated by neurologists. And she developed the neuroinvasive form, and she became completely paralyzed. And I spoke to her several years later, and she had not regained the use of her legs at that point. But she actually kept I remember her because her attitude was just one of the best attitudes I've ever seen in any patient. She was always happy. So going back to the issue that I mentioned before about why the brain looks normal, the basic scientists have actually known this for some time. Meaning they find a lack of evidence for encephalitis, which is an inflammation, brain edema, in West Nile virus infected hamsters, even when they are about to die. So the brain, the encephalitis, we'd have to debate as to why people with encephalitis die, but the answers are not going to be so clear cut at this point. This is the example I was commenting about herpes encephalitis. This is a deadly encephalitis. It's almost as common as West Nile virus encephalitis. West Nile virus has become the #1 cause of sporadic encephalitis since it entered North America. But this is typically what you see here in herpes encephalitis. You have severe hemorrhages, typically in the temporal lobes. The parietal lobe is also affected here. And in this particular case, the entire right temporal lobe has been destroyed by the viral infection. This type of massive injury you cannot live through this type of massive injury. So our contribution to the West Nile story came in 2002 when we saw 3 consecutive cases of acute flaccid paralysis. At that time, we were under the impression that it might be due to the Guillain-Barré syndrome, which is a peripheral nerve process. But we saw 3 cases, and we quickly realized that this was actually not due to a peripheral nerve problem. It was due to a central nervous system problem that was very similar to poliomyelitis. The first case was a 56-year-old man with fever, chills, nausea, vomiting, sweats, achy muscles, confusion, and stupor, but he was not comatose. He had bilateral arm weakness. He had a complete flaccid paralysis of the right leg. He was areflexic. He had bladder incontinence, no control of his bladder, and he developed acute respiratory distress. He did not complain of any numbness or tingling or paresthesias. This is more or less tingling. He was diagnosed with many different diagnoses, but stroke, Guillain-Barré syndrome, and critical illness, myopathy were some of the most plausible alternative diagnoses. The MRI of the brain was normal, and his C-spine was also normal, and his spinal tap was also normal. So even an abnormal spinal tap and analysis of spinal fluid is going to be dependent to some degree on the timing. MRI is notoriously dependent on the timing. If we were able to do daily MRI scans on every victim who has encephalitis, I assure you we would see we would light up with abnormal areas, but we can't do that. And so it's like getting a Polaroid, a snapshot in time, and it is really hit or miss. In fact, I've had cases where I ordered an MRI, saw the abnormality, repeated the MRI, and the abnormality was gone just 1 or 2 weeks later. And so in this individual here, he's requested to prop both feet up the same, and you can see that there's a severe drop foot here on the right. In this particular diagram, he was actually instructed to flex both hips up, and this right lower limb was, completely lifeless, paralyzed, and had no tone whatsoever. I'll go to the third case. It was a 49-year-old man, nausea, vomiting, headache, some diarrhea. It was a question of whether or not he had some mild confusion, but the major chief complaint was right arm acute flaccid paralysis. He was areflexic. He actually had no fever, which is interesting, but I've seen it before. He had no pain, numbness, or altered sensation. He was diagnosed. He actually had about 12 different diagnoses, but food poisoning, injury to the peripheral nerves in the arm, spinal cord injury, stroke, and finally malingering. He was actually kicked out of the emergency room because he went, I think, 3 days in a row. By that time, because of the prior 2 cases, we were already doing media brief segments and warning the public about West Nile virus poliomyelitis. He was on the coast, and he actually called and said, look, I think I have that condition. And so we actually saw him, and sure enough, he actually had, CSF, by the way, was not done on his case. And this is the same individual where I saw him maybe a month later, and you can see that there's atrophy. The entire right upper limb is wasted. It's also flaccid and lifeless by his side. Here he was asked to elevate both arms. You can actually see the onset here of atrophy and wasting. You see that there's no deltoid here. It's just kind of the bone here that you see. And even in the hands, you see the early wasting of intrinsic hand muscles on the right compared with the left. The right, unfortunately, was his dominant hand. We did many electrodiagnostic studies. I'm not going to bore you with them, but what we found here was absent or reduced motor responses, normal sensory responses, and the deficits were always asymmetric. They were not symmetric. It wasn't like you were dealing with bilateral foot drops and bilateral, hand weakness or bilateral shoulder weakness. That rarely occurred, and it never occurred in all four limbs. So the hallmark here was an asymmetric type of process that was destroying either nerves or motor neurons within the spinal cord. And based on the electrodiagnostic studies, it was very easy to determine that this was coming from the motor neurons. And so the impression, even after our first case that we evaluated in 2002, was that of West Nile virus poliomyelitis. What we didn't expect is that when we went to the internet to look up poliomyelitis due to the West Nile virus, there was no literature on that topic. We also obtained pathologic confirmation in 2003. This gives you an example of a motor neuron with a centrally located nucleus here and an axon. This is the motor axon. And that one motor neuron is going to supply several hundred muscle fibers. And so you can see what happens when you start losing these motor neuron connections. You start getting weak in hundreds of muscle fibers. And this shows a similar motor neuron that's on its way to dying, either through a mechanism we call apoptosis or because the virus has entered the motor neuron and is multiplying and duplicating, and the contents are going to burst out. Okay, this here is the very eccentrically located nucleus compared to a normal cell, and here you have the remains of a dying motor neuron, something like this, and what's left of the remnants of that motor neuron. So it's not an uncommon complication. And even now, I've actually noticed that it's probably more than 25. This is old data from 2004, saying it's 25% of hospitalized patients. The reality is, the last two cases that I've seen, you have to do a detailed neurological examination because there was a case that no one saw the fact that he was clearly weak in the right lower limb. He had a partial foot drop that was just not documented. And in another case, the right shoulder was weak, and that was also missed. So there's probably other forms of poliomyelitis and acute flaccid paralysis that are not so severe that are almost certainly being overlooked. I saw him 13 years later in 2005. And he was still very weak in the shoulder muscles. He had poor abduction. Actually, this is abduction. He had poor forward elevation and external rotation. But this is where we calculated he had lost anywhere from 95 to 99% or 98% of his neuronal motor connections. In contrast, where he had only lost 60 to 80% of those connections, he actually had a very good outcome. And so his right hand and the fine fractionated finger movements in the right hand were actually working well. I couldn't tell that there was any problem with his right hand in the past. So the body does a marvelous job of healing. Anyone who's ever seen a picture of literally 80, 90, 100 mechanical respirators lined up under one roof in polio victims in the 1940s and 50s will understand that those victims, most of them actually lived, and eventually the body was able to breathe on its own. They were able to leave those mechanical respirators where the whole body actually lay there for weeks, sometimes months. But the take-home message for the neurophysiologists in the audience, and I know there are a lot of you here, is that the temporal profile of recovery from this condition is really dependent on how many neurons are lost initially. And so right now I'm seeing a patient upstairs who has bilateral facial paralysis. When I ask him to close his eyes, he can't close the right one. He partly closes the left one. He can't swallow, so they had to put in what's called a stomach peg tube to feed. And when he speaks, it's very slurred speech because the virus actually attacked the motor neurons in his brain stem. And interestingly, he can't bite down either. The nerves that cause facial expression are different from the nerve that causes ability to clench your jaw. And so, but it told me that, and he could feel the sensation in the face is perfectly normal. And so the virus targets. This is a neurotropic virus. It skips those sensory fibers, doesn't care about them, and it targets only the motor neurons, the ones that control movement. And so he can't close his jaw, and so they've actually had that athletic tape going from here to here that's keeping his jaw from literally just flinging open. And so brainstem involvement, again, is not at all uncommon. In this case, there was a left facial paralysis. This is the paralyzed side. So he was unable to close the left eye and no movement here of the cheek. I'll talk a little bit about making the diagnosis of West Nile. Because the diagnosis actually depends on the presence of this antibody, the IgM. The IgM is the initial antibody that's formed after the introduction of the virus into the body. And here is that incubation period that I was talking to you about. And here is the clinical symptoms, and you have the production of the IgM antibody. And then you have the IgG a few days later beginning to form. This particular antibody is the one that we believe persists for eternity. And this is the one that confers and generates lifelong immunity. Now, there are problems with the lab tests. Part of those problems are self-made, man-made. Part of them are not. I see about a half dozen patients a year who come in and tell me, Dr. Leis, I have West Nile virus infection. I said, okay, well, why do you say that? Because my blood work showed the virus. I said, well, the virus actually is eradicated very, very quickly from the human body. I'll show you just how quickly that occurs in one slide. And so it's probably not the virus, but you probably have the antibody that suggested the virus, and they say yes, and they show me their blood work. And they show me that they're IgG positive. I said, what happened to the IgM? That one doesn't matter. That one was negative, but my doctor tells me I have West Nile virus infection. I say, okay, so I want to just take a moment to review, because I'm probably going to review this every time I lecture from now on, because it's a misunderstanding of, unfortunately, gross proportions. An IgG positive, as I've had, and I see, again, 6 or 7 every year. This is from Mayo Clinic's lab, and this is exactly what the report reads. IgG antibodies to WNV detected, suggesting recent or past infection. Okay, I don't necessarily have a problem with that, except that you cannot interpret an IgG antibody without the IgM. And so, the IgM reads IgM, negative report explanation, there is none. So this is one of the top institutions in our country where they don't report. If you're IgM negative, they say nothing. This combination can only be interpreted one way. This combination rules out West Nile virus infection as a cause of any new or recent symptoms. Why? Because the first antibody to be produced is going to be IgM. You cannot make a diagnosis of a recent or an acute West Nile virus infection without IgM. The IgG positivity, remember, it stays with you forever. The IgM has to be done, has to be reported, and this really is a misleading report. And it occurs that there are actually, in commercial labs, there are actually some worse reports about IgM being cannot be used to confirm an acute infection because it can last for 500 days or longer. That's so confusing. But this is why we see every doctor sees patients who are convinced that they have West Nile virus infection because their doctors are reading this. It suggests recent or past infection. They don't know the difference between IgG and IgM. And so they're informing their patient, yes, you have a recent West Nile virus infection. Again, in the presence of a negative IgM, no. It actually excludes a recent West Nile virus infection. So this is that 80% are all going to be IgG positive and IgM negative. And there are several million Americans who have that combination. And in particular, these patients, given just the normal aging process, they're going to go in there. There are going to be maybe hundreds of these millions who have unexplained symptoms, and then the doctor's going to check West Nile virus infection. And they're going to get that report. And they're going to say, yes, your symptoms are due to West Nile virus infection. So we as clinicians and as physicians, we have to do a lot better job of controlling how labs report the results. This is a misleading lab. Okay, unfortunately, there are bigger problems than misleading West Nile virus test results. There's absolutely overwhelming evidence that most doctors never order any West Nile virus testing. So this is one study. This is a group from the Phoenix area. The title is Completeness of West Nile virus Testing in Patients with Meningitis and Encephalitis During an Outbreak. So this occurred in the summer months. They reviewed cases of meningitis and encephalitis during a West Nile virus outbreak in the Phoenix metropolitan area. Of 60 patients identified with meningitis or encephalitis, only 24 of the 60 were tested for West Nile virus. The rest were left with, quote, unexplained meningitis or unexplained encephalitis. We have to actually take a step back and try to determine why the doctors were complacent enough to allow and be happy enough to allow a diagnosis of unexplained meningitis or unexplained encephalitis. And I'm going to tell you at the very end why it's so important that you actually obtain a definitive diagnosis of West Nile virus infection. Well, the conclusions by the group from Arizona was, and these are all direct quotes, lack of testing results in substantial underestimates of West Nile virus neuroinvasive disease burden. We would expect the proportion of cases tested to be even lower in non-outbreak settings. Meaning if you're the 1 or 2 or 3 or 4 cases in the United States that occur in February, you're out of luck. the chances of anyone checking you for West Nile virus are going to be low, real low. Second case. This is from Christy Murray and her group in Houston. They examined the proportion of tests ordered in a WNV endemic area, which was the Houston area, from 2005 through 2010. And this was during the peak seasons, and patients who presented with meningitis and encephalitis. 9 hospitals took part in this particular study. The results, only 281 of 751 patients with clinically compatible meningitis or encephalitis were tested for West Nile virus infection. That's 37%. So one study, multiple hospitals, one state, another study, different states, multiple hospitals, 40% compared to 37%. The majority of cases who go to the hospital, who go to the emergency room with West Nile virus encephalitis are being missed. Conclusions, they concluded there is substantial underutilization of West Nile virus testing in routine practice. That's one thing else, something else that we have to change. So let's change directions. What's new in West Nile virus? I put autonomic nervous system dysfunction, also known as dysautonomia, as something new, but it's actually not new. We actually saw it in autopsy cases in 2002. So what's happened is that it's very, very under-recognized. And I will just tell you that one of our support group members actually developed a bloating of his stomach, and they were I think I actually had the reports, the ER reports. He came into the emergency room with a bowel obstruction. A CT of the abdomen and pelvis here shows evidence of a distal bowel obstruction. This person had gastroparesis. He had gastroparesis from involvement of the West Nile virus. Because West Nile virus is a neurotropic virus, it can certainly target motor neurons in the brain and spinal cord, and it also targets autonomic nervous system neurons. The other thing that's new that we have to get a handle on and try to determine how pervasive is this is something we call PIPIS. Okay, something I call PIPIS. Okay, it's a post-infectious pro-inflammatory state, and there are clearly other individuals who are working on the same thing. I'm going to show you some very quick work, but Christy Murray and her group in Houston also found a number of elevated pro-inflammatory proteins that are high in patients who have persistent symptoms after West Nile virus fever or neuroinvasive disease. So it's important for us to actually get a diagnosis of West Nile because I have had only one patient who I had luck with treating for this condition. And she got much, much better when we treated her with immunotherapy. But immunotherapy with intravenous immune globulin is $50,000 a month. And the insurance companies would not allow treatment, and they would not allow treatment, and I went through 3 appeals because I could tell from the symptoms, the gastroparesis, the abnormal sweating, the tachycardia, the fact that she had developed orthostatic hypotension. She would get up and feel faint, or the racing heart. The heart rate would go from 150 to 30s. I mean, literally with no precipitating action or movement. And so this type of dysautonomia was very prevalent, very predominant. And finally, after striking out 4 times, I called the insurance company back, and a good soul told me, he goes, Dr. Leis, look, I feel for you. Have you ever thought about POTS? I said, well, POTS. I'd heard about POTS. I'd never thought about it. But POTS is postural orthostatic tachycardia syndrome. And depending on the insurance company, some will have that as a diagnostic code that they will reimburse for. And so he didn't tell me anything else. I said, well, on my own, let me see if I can go ahead and let me go ahead and reorder the IVIG with a POTS diagnosis. He goes, that would be ideal. And so I did this, and she actually had a marked improvement, and we were able to repeat the autonomic studies, and at Mayo Clinic, they're done really well. Maybe the lab doesn't report quite so well, but the autonomic nervous system studies are done really well, and it showed how do they call it? This is a night and day difference on the IVIG. And so now she will continue to receive IVIG for as long as her body needs it. Big difference. So again, autonomic nervous system controls all the automatic functions of the human body. Heart rate, blood pressure, breathing, digestion, bowel, bladder, sweating. And impairment in all those systems and all those symptoms typify the autonomic dysfunction or the dysautonomia. So I want to tell you about a case in 2002. This was a 79-year-old man who had 6 days of fever, vomiting, abdominal pain, distension. No one operated on him. Bladder incontinence and chest pain. He was confused. He actually had acute respiratory failure and required mechanical ventilation for 8 days. And he had 3 limbs that were knocked out. And so he was completely immobile in the lower limbs and the right upper limb. He had flickers of movement only, but the left lower limb was 5/5. He had normal function in the left leg. His blood pressure was extremely labile. He had severe orthostatic hypotension. And so when I was attending that particular, for that patient, I took the team in, and we engaged in the conversation, and he seemed a little bit, like he needed the head of the bed rolled down, so a nurse actually, would you like to head down so you can, no, I'm sorry. His head was down, but he was having to try to lift the head up to look at me, engage in conversation. And so the nurse lifted up the head of the bed, and he stopped talking. I said, what happened to Mr. Jones? And he goes, I said, he couldn't have fallen asleep. I said, roll down the bed goes down, he starts talking. I said, raise up the bed, head of the bed goes up, and he stops talking. And so he had such prominent orthostatic hypotension, and when we did this, the blood drained from his brain, and he literally lapsed into a coma. And then when we lowered it, he would re-engage in the communication and conversation. He also had cardiac dysrhythmias. Blood pressure was all over the place. The heart rate was all over the place, 40s to 120s. He had loss of bowel and bladder control. He had the intestinal pseudo-obstruction. That's the term, pseudo-obstruction, because it's not a real bowel obstruction. And he was discharged. We transferred him over to the VA. He was discharged and then died suddenly. And that was actually no surprise. Anyhow, when this is from, I don't know if it's his autopsy, but this is the cervical sympathetic ganglion cells. These are the ones that actually can go directly into the heart and control the heart rhythm. And what you see here are dying sympathetic ganglion cells. They're being ingested, they're being destroyed. And this is something that the veterinarians and the basic scientists have actually realized also for some time. This shows the gut of a hamster developing this pseudo-obstruction after being inoculated with West Nile virus. This is fairly typical compared to the sham, which is also inoculation but carrying no virus. They also look at heart rate variability, and it was suppressed in West Nile virus infected hamsters. Cardiac pathology was observed by day 9, and the cells infected the SA and the AV nodes that control heart rate rhythm. Their conclusion was that this data should model autonomic nervous system dysfunction of human West Nile neuroinvasive disease. Now, there is hope on the horizon. This came out last week. Actually, maybe even earlier this week, yeah. And so the title is what it made me happy when I read it. Sensory and Autonomic Involvement in West Nile virus-associated acute flaccid paralysis. I mean, hallelujah. I mean, there's very little literature on this condition. But you can see here that there is atrophy of the right side compared to the left, and the team that evaluated him had actually made notice that there was discoloration below the knee, and the patient had bladder dysfunction and a little bit of bloating type of symptoms, and based on that, they determined that there was also autonomic involvement, and they were correct. And to their credit, I read the report and I thought, gee, this is missed so often. You know, a little bit of discoloration in the limb that's atrophied and weak. You're going to be attributing to pedal edema, the swelling, or what have you. But they were this very good clinical work. So there's no specific therapy. It's supportive, and you do all these things: hospitalization, IV fluids, nutrition, ventilator support when needed, prevention of secondary infections, good nursing care, and there are no good human clinical trials. I remember I was not part of it, but there was an NIH-sponsored trial, and after 2 years, it's like they had like 6 patients. You can't get a trial with that type of those type of numbers. You need 600, not 6 or 10. And in fact, the trial failed because the clinicians who were taking care of those West Nile patients, even though they had actually agreed to the trial, on day 3 or day 4 or day 5, or in those days, you'd get the confirmation after about 10 days. But, if your patient is dying, if your patient is going downhill, if your patient's developing bulbar symptoms, can't swallow, facial, drops, foot drops, losing function in an arm, I'll tell you something, you're going to do anything in your power to try to keep that from going progressively downhill, because you know what the consequence is going to be. And so there were a lot of clinicians that between second and third week, they were just saying, hey, the heck with this, man, I'm giving him high-dose steroids, I'm giving him something else, anything, to try to treat which is a decline in overall function. Now, in 2002, 2003, we also saw there was a clinical enigma. The fact is, the West Nile virus is very quickly eradicated from the human body. I used to tell them that by day 10. The virus would be gone, and there was a rule of 10s that Lyle Peterson, who actually was head of the CDC, I think the arboviral section, he told me on the way to the airport. He said the rule of 10s. After 1 day, 10% are going to have the antibody. After 4 days, 40%. After 8 days, 80%. And by day 10, 100%. And by that time, all the virus is going to be eradicated from the human body. I thought, Lyle, I'm seeing new neurological symptoms that are developing long after day 10. And we needed an explanation. Not to mention, even cases of the West Nile fever were having lingering, protracted, prolonged, recurrent symptoms. I remember one football player from the coast. I mean, he had, these recurrent headaches, and I remember he and others, whenever they developed another upper respiratory infection or viral infection, they really felt like they were getting reinfected with West Nile virus. And so there had to be an explanation that was not tied to the short lifespan of the virus. Okay, so to give you an idea how difficult it is, from 1999 through 2002, 4 summers, CDC reported 0. No West Nile virus isolations from humans in the Western Hemisphere. Of 2,600 cases in USA, 0 cases of West Nile virus isolation. All previous attempts to recover the virus from human patients failed. The first virus was actually isolated from an immunocompromised lymphoma patient. Both the lymphoma and the treatment for lymphoma are going to knock down your immune system. But we still had to wait 4 summers to recover the virus. Since that time, we know we can recover the virus. My brother, who works at Mayo Clinic and does the bone marrow transplants, there's about a 2-week period before he does a stem cell replacement where his patients have 0 immune function. It's a complete immunoablation, a complete destruction of the immune system. And throughout the years, he's had patients who actually get infection. And when they get this type of viral infection, they die. So there's no doubt you need a good immune system. We have enough evidence, like the case I told you about the young lady with myasthenia gravis who was already immunocompromised. The virus, in high likelihood, would not have done anything else to a 29-year-old had she had a workable immune system. So the questions we raised: why do we have all these delayed symptoms? And is there a biomarker? Is there something we can go ahead and track? And I show this case again because this actually developed in the 3rd week after the onset of symptoms. And that's a good 2 weeks after the virus is thought to be eradicated from the body. We also described 6 cases where, this is a reverse from the case I was talking about just recently, 6 cases where they developed myasthenia gravis. It is a classic autoimmune disease. Classic. So they developed myasthenia gravis about 4 to 7 months after they had the neuroinvasive form of West Nile virus infection. And so we actually started looking at something called S100B, and to make a long story short, what we found was that S100B is absolutely increased in neuroinvasive human autopsy tissue. It's also increased in human bloodstream, in human spinal fluid after the infection. It's increased in the cells of the brain after exposure to even inactivated West Nile virus particles. That work was done here at UMC, the University of Mississippi Medical Center, by Dr. Kuwar and Dr. Vig, who is a professor of biochemistry. And the green stuff here is immunostaining of S100B. This is a patient who had a nerve that arose from the spinal cord, and you can clearly see the difference. Green staining is the S100B. This is what the nerve should look like. This is what it actually looked like on autopsy study. Now, at the same time we were looking at S100B, another group was looking at something called HMGB1. This is Frazier and his group, and they published it in Vital Research, and they found that HMGB1 levels were elevated, the same way as S100B, they were also, the concentrations were significantly higher in neuroinvasive disease than in healthy controls, and significantly higher levels were associated with neurological symptoms. So, what do S100B and HMGB1 have in common? They both bind to the same receptor. And this receptor is called RAGE. And RAGE does one thing really well, and that is that it increases an inflammatory response in your body. And so we speculated that it could be due that the delayed neurological deficits, the persistent, prolonged, recurrent symptoms, could indeed be due to these two pro-inflammatory proteins, because they both work on the same molecule. Now, I want to point out one thing to you, maybe I shouldn't, but okay. Well, anyhow, there are 9 cases here of West Nile fever, 9 cases where the HMGB1 pro-inflammatory protein was elevated. And when we look back at our data, we had 62 cases of West Nile fever, and 42% of them had elevated S100B. In their study, they looked at 22 cases of West Nile fever, and 41% of these cases had elevated HMGB1. And so what that told us is that there's a commonality here, and it's probably not that these cases were actually West Nile fever. These cases here were almost certainly should have been shifted over to this group, which was the neuroinvasive disease group. And this is one of the things we concluded also. These 42 cases, because S100B only comes from astrocytes in the brain. And you have to have brain injury. This has been used as a biomarker of brain injury for, 2 decades or more. And so we determined that these WNV fever cases are actually causing leakage of proteins from the brain and spinal cord into the bloodstream. So the implications are that many cases, and in fact 40% of cases that are classified as fever are actually biochemically neuroinvasive. And it does offer a general explanation for why patients have residual symptoms in what had heretofore been described as a relatively benign summer flu. Number 2, the current CDC classification scheme is probably inadequate, because they do fail to account for neuroinvasion in a large proportion of West Nile fever cases. And it provides a compelling argument for reviewing the criteria of just how they do the classification. So our biomarker and the biomarker evidence of Frazier and his colleagues suggest that 40% of West Nile fever cases are actually neuroinvasive. So those of you in the room who had just West Nile fever, there's a possibility that you actually had meningitis and or encephalitis. Had someone put a needle into your back and measured the spinal or analyzed the spinal fluid, we would have known, and probably you would have been classified differently. But again, it's a high proportion of people who are supposed to have a condition that is self-limiting. Okay, I'm going to go by this activation of RAGE. RAGE does a lot of things. It also causes promotes myasthenia gravis. And so this slide kind of tells you kind of where we are with this. S100B, HMGB1, RAGE is activated, increased inflammatory response probably explains or certainly contributes to this and to the formation of possibly promoting myasthenia gravis. And it's a possible explanation for why we saw 6 cases, although 5 of them were from Mississippi, 1 was from Arizona. Now, more recently, we looked at something called osteopontin or OPN. This has been a traditional cancer biomarker. And I'm just going to read here. OPN is induced in multiple neuroinflammatory diseases. In the study, we found that WNV infection induced OPN expression in both human and mouse cells. In fact, in the human group, These were individuals who had already recovered, months before, had recovered from neuroinvasive disease. And so the OPN does play a pathophysiological role in cancer. And it has been implicated as a prognostic and diagnostic marker for a number of different cancer types. And when I was at Mayo Clinic, they actually had a glioblastoma, which is a deadly cancer that formed within 2 years after a patient had severe neuroinvasive disease. And back here in Arizona, back here in Mississippi at UMC, they had a case of a very rare tumor that is almost, number one, it's rare, and almost always it's very benign and associated with focal seizures. In fact, when they find the tumor, they don't automatically take it out. They see if it's, growing, it's considered a benign. 15, 20 years ago, it was known as a hamartoma, and hamartomas you just left in because they weren't going to do anything bad. Well, this one did a whole lot of bad. This one occurred 8 months after the onset of his neuroinvasive disease, and he was dead in the following year. And it's probably one of the few cases, if ever, this is called a DNET, D-N-E-T tumor, this embryonic neuroplastic, neuroepithelial tumor, and this tumor spread like wildfire, seeded the entire what we call leptomeninges, and this patient died relatively quickly of a tumor that was supposed to be benign. And so those two cases actually prompted us to start a survey. What's it called? Survey Monkey? Okay, Survey Monkey. Okay. And which we were asking patients who have had neuroinvasive disease if they've ever developed cancer. So hopefully we'll be able to determine whether or not there's a link between West Nile virus infection, the production of all these pro-inflammatory proteins, in particular the production of OPN, and whether or not there's actually a spike in the year or two following neuroinvasive West Nile virus infection. So this is the kind of the final diagram here. We now know that there are a bunch of cytokine, important pro-inflammatory conditions and proteins that are produced by the cancer. I want to just go over just a couple more slides. This is one of the important groups, also from Dr. Murray and her group from Houston, and they looked at prolonged fatigue after West Nile virus infection. And the results, 31% of these patients had prolonged fatigue for greater than 6 months after infection. The average fatigue duration was 5 years. Females were more likely to report the fatigue, but importantly, they found all these pro-inflammatory cytokines. And so whereas we were looking at those 4 or 5, they found this particular cytokine to be elevated, interferon gamma inducing protein 10, and interleukins, the IL-2, 6, 12, and we looked at IL-17. So West Nile virus changes the immune picture in your body. And their conclusion and recommendations, clinicians should consider WNV as a possible factor when evaluating causes of prolonged, unexplained fatigue. And so this slide is also important because we looked at all the symptoms, and we look here, you have bloating as one symptom. It was present in 48% of their patients. Bloating is an autonomic nervous system function. You had night sweat. Sweating is controlled by the autonomic nerves. Skin sensations can certainly be contributed to or controlled by autonomic nerves. Dizziness the same way, particularly if you have orthostatic symptoms. Blood pressure regulation is autonomic. Abdominal pain could be autonomic. Irregular heartbeat is autonomic dysfunction. and even diarrhea could also be autonomic driven. And so we're actually painting a picture where this PIPIS syndrome, this post-infectious pro-inflammatory state, is going to have a better defined description, hopefully in the near future. So, specific therapy, I'm showing the slide. Supportive care is still the standard. I'm not that much of a maverick, but immunotherapy to control this state with either high-dose steroids, intravenous immunoglobulin, or other immunosuppressants, I think is where we are headed. And so I'm going to stop right there, and we'll go ahead and field questions. I got a good drink here. Okay. Any questions from within the support group? Go ahead.
Is it possible that occipital neuralgia is related to
Mm-hmm.
there's possibility that kind of?
The question is it possible if occipital neuralgia could be contributing to the meningismus and the nuchal rigidity in these cases of meningitis? And the answer would be no. The people who've seen the occipital neuralgia, it's very classic. It's very classic. In the ER, I used to inject lidocaine into the nerve just to block at least temporarily block the nerve from acting up. The nerve can be damaged in people who have rheumatoid arthritis, because in those people they have something called the top two vertebrae can slide on each other because of the arthritic process, and it can actually begin clipping either one or both of the nerves that contribute to the greater occipital nerve. But no, these would not. They should not be misdiagnosed by anyone who's seen more than one case of meningitis or more than one case of occipital neuralgia. Any other questions? Please.
How long after you, like I had encephalitis, how long after I have that can I get something again?
Okay, so the question is, how long after I recovered from encephalitis can I start seeing new symptoms? And the answer is, hopefully you will never see new symptoms. What I'm painting here is a picture of cases where we actually unfortunately do see persistent symptoms or recurrent symptoms. But mainly they're prolonged. So if you look at fatigue, which Dr. Murray's group did, even in 1999 to 2000, it was already noticed that fatigue was the number one persistent symptom 12 months after hospitalization for West Nile virus infection. So if you were hospitalized, you were actually 2/3 of patients still had this type of disabling fatigue 1 calendar year later. Okay, what we didn't know back then is that it was due to all these, changes in the immune system, this pro-inflammatory state. And so hopefully you won't develop anything new, but if you do, then you probably should let your internist know. You should please, by all means, you guys are now, and gals are now, advocates for West Nile virus. Most of you have been here, some of you since 2002, and you have to educate the doctors out there who are not even ordering the tests. Okay, so hopefully you won't. If you do, I certainly would like to know about it. Yes.
My question was going to be, like you were just saying, a lot of doctors don't test. And what would be and with the doctors that do test, it takes a long time for them to come in, some weeks, some days.
Well,
So what is something that doctors could see to help? And what would be the benefit if they caught it before the test got here?
Well, the reason to actually make a diagnosis is that then we can actually look for some of these elevated cytokines, So because I knew that West Nile virus has a pro-inflammatory state, I have been doing what Dr. Murray's group has been doing also. And we now have about 3 cases where tumor necrosis factor, another powerful cytokine, is elevated. And these are cases where they had West Nile virus infection months ago. And so when you have this, my next step, hopefully, is to be able to convince insurance companies that this is a viable condition. And so what Connie and I are working on right now is trying to find insurance companies that are going to allow treatment with a tumor necrosis factor blocker, an inhibitor. And I'll tell you that in the current climate, that's going to be very, very difficult. I don't know if we're going to be able to do that because there is no diagnostic code for this PIPIS state. And without a diagnostic code, BCBS of Mississippi, Blue Cross Blue Shield, is not going to pay. Should they pay? Absolutely, they should pay. Okay, are they going to? They're not going to recognize the diagnostic code for this pro-inflammatory state. And so, but we have elevated, 2 or 3 cases of elevated TNF, and drugs like Humira, Remicade, these are used for arthritis and other autoimmune conditions, are the treatment of choice for their TNF inhibitors. And so we're going to try to convince insurance companies that, hey, the diagnosis is elevated TNF. This is what you see in other autoimmune diseases. That's why they developed TNF inhibitors like Remicade and Humira, and there's about 3 or 4 others. And the problem is most of these are injectable, and I don't know the cost, but it's going to be tens of thousands of dollars. The IVIG, the intravenous immune globulin, is $50,000 per month. And insurance companies, I understand, they function for a profit. I just don't want them doing that. Okay. Any other questions? Yes. Okay, so the question was, my father was diagnosed with spinal fluid that showed IgM and IgG positivity, and he was diagnosed as a false positive. No. Unfortunately, the doctor who said that had no understanding, because the presence of these antibodies in spinal fluid is unequivocal evidence of production within central nervous system. That's just blatant misinformation. Okay. Yes.
Does the exhaustion ever get any better?
Question, does the exhaustion ever get any better? I hope. It can persist. There can be some better days and some not so good days. I wish that I could say that, maybe with treatment in the future, it might. I think that Dr. Murray is right on when she says that there's a correlation between that fatigue and all those elevated cytokines. And what we need is to organize better than we've organized in the past. Okay, and we need insurance companies to come up to the plate, do what they're supposed to do. There are cytokines galore that are elevated in patients who survive this infection. And you ought to be able to use some of the more modern immunotherapy. And no, these patients shouldn't be required to have, 4 months, of high-dose steroids. Steroids are the last drug that I would use for anyone. And no one can remain on steroids for a prolonged period of time. It is too dangerous. So IVIG would be the proper drug. It is not an immunosuppressive, but yes, every one of her patients that had elevated cytokine levels, I would put on a 4-month trial of IVIG. It's used in virtually dozens of other autoimmune conditions. But again, they carefully look at the diagnostic codes, and lately I've really struck out, and it's been so frustrating because I can't get them to pay for, and it's not just BCBS, it's other insurance companies, but I can't get them to pay for antibodies that I know are causing the symptoms. It's soured my whole perspective of medicine. Any other questions? Let's go ahead and take what's next?
Chat questions. I will read the first one to you.
Okay.
I'm currently 37. I was stricken with an extremely rare form of immunocompromised.
Can I interrupt? Can everyone hear you reading that, or do I have to repeat all that?
You come up there.
Yes, please. Okay, that'd be ideal. Okay. First question.
I'm currently 37. I was stricken with an extremely rare form of immunocompromising West Nile virus in Albany, New York during the summer of 2012. My body was impacted in a GBS-type paralysis. I have left leg, knee, foot drop paralysis considered permanent at this point. I've seen many specialists throughout the eastern seaboard and have not found any helpful treatments to deter the virus from further impacting the body, for example, causing increased muscle atrophy and nerve pain, or quelling my chronic pain. Are you aware of any medicinal and or medical procedures successful in treating the virus?
Okay, two things. Number one, I can almost assure you the virus was actually eradicated from your body the first week. So this is not due to persistent viral infection. We may whistle a different tune, but right now the evidence is overwhelmingly in favor of the virus being easily eradicated from the human body. So that's not the problem. The problem is, by the way, number two, you never had Guillain-Barré syndrome, okay? That was the prevailing diagnosis from 1999 through 2002. I assure you, this is not the result of residual Guillain-Barré syndrome. Guillain-Barré syndrome is an autoimmune peripheral nerve process, and it is symmetrical. The fact that you have one leg that has atrophied and wasted away, and not the other leg, and not the arms, tells me that the presentation is much more in agreement with the acute flaccid paralysis that's due to destruction of the gray matter of your spinal cord that houses all those motor cell bodies. I would say that's highly likely is the case with you. With respect to treatment, I showed you the example of one individual who 13 years later still had very poor ability to lift up and to control the proximal muscles of the right upper limb. And that was because I had also done the mapping of his motor neuron connections and determined that the size of the response was only less than 2% on the affected side compared to the unaffected side. So I made the assessment that he lost the vast majority of those motor neuron connections. And so what you're painting is a picture like someone in the 1950s who would have developed polio. And I think most of us have, at one time or another, have seen a polio victim. And a very small leg that doesn't support any weight, kind of a shriveled small leg, that also doesn't grow like the normal leg in size, or the same thing with an arm or a hand. I wish I could tell you that there's something at this point. The answer is no. There's nothing at this point. Everything is unfortunately going to be symptomatic, meaning if you have pain, then you're going to have to try to determine which medications alleviate the pain the most. A very good combination is what's the trade name for Lyrica? What is it? Okay, never mind. I don't have any disclosures with Lyrica, but the combination of Lyrica, which is pregabalin, with a combination of duloxetine, also known as Cymbalta. That's a really nice combination to take the edge off of most nerve-related pain syndromes. So the dose of the Lyrica, you can go up to 300 milligrams per day, and the Cymbalta or duloxetine, you start at 30 milligrams daily, and then your maintenance dose will be about 60 milligrams daily. Okay, I hope you do. I hope you at least feel better.
The next question is, immunotherapy different for each patient with West Nile virus?
The question is immunotherapy different for each patient with West Nile virus? The reality is that there is no uniform immunotherapy at this time. Again, it's all, we try to get this through insurance companies because all the newer agents are very expensive and they're prohibitive. No one can afford to spend that kind of money for a new medication. But we don't have any structured immunotherapy program to treat this post-infectious, pro-inflammatory state. I was just kind of telling you in my perfect world, I would be giving everyone a trial of IVIG to start with for 4 months.
The next question says, hi, Dr. Leis. Thanks for providing this opportunity. We've learned a lot through the medical literature that following clearance of the virus, that a sort of autoimmune effect can persist, perhaps what you have referred to as typhus, for some time, where microglia in the brain become hyperactivated and stuck in the M1 phenotype and firm synapses, leading to memory loss, near dementia, and other neurological deficits. Yet there are a number of drugs, such as monocycline, besides IVIG, and even over-the-counter compounds, such as sulforaphane, that reverse this M1 to the more common anti-inflammatory M2 phenotype. I'm wondering if this would be helpful and why this is not better known and why it isn't a common treatment before significant and permanent damage is done.
Wow, I love that comment. And so what this person is doing is he or she has recognized that there are agents available that, at least on paper and biochemically, there are solid reasons for why they should work and do work. That knowledge is I mean, whoever this is, I have to get in touch with you and learn from you because I don't know what these drugs are. And so that'd be number one. But I do have experience with ALS, and I know minocycline was used in a large double-blind, multi-center trial of ALS, and there was no benefit that was shown with at least Lou Gehrig's disease. But I think it's a great idea that you take a drug like minocycline and maybe take other drugs, high doses of vitamin C, and even some of the over-the-counter medications. I think L-serine is another one, and in combination, try to give it to these patients. I would actually need kind of a structured protocol from whoever you are, but thank you very much. That's very important. I didn't even talk about it because I don't have the knowledge to talk about it.
Is there any suggestion of correlation between history of shingles and increased susceptibility to NIV West Nile virus?
I'm sorry, to what kind of West Nile virus? Oh, okay, to neuroinvasive with shingles. Not that I'm aware. So there shouldn't be. The shingles virus is a chickenpox virus, and it lies most of the time dormant within the dorsal root ganglia, which is where the sensory neurons lie, and during times of stress or weakened immune system or concurrent illnesses like cancer or other illnesses, the patients can develop shingles, the typical shingles rash. I don't think that there should be a direct connection between the viruses, other than the fact that maybe both might be predisposed to being more neuroinvasive during times of the stress or during times of concurrent other illnesses.
That's the last question via the chat. At this time, if anybody would like to unmute their phones or their computers and ask a question, we can hear you in the room if you'd like to do so.
You can change your name on the Clubhouse also to him, and you can have a connect.
Doris, we see that you're unmuted. If you have a question, you can go ahead and speak. We have one more chat question.
Okay.
It says, hello, Dr. Leis. In response to your comment about developing new neurological problems years later, I had West Nile virus E in 2012. I was 36. I had paralysis in legs along with all of the usual symptoms. I seemingly recovered quite well. 5 years later, March of this year, I came down with the flu. Not only did I experience most of the same symptoms of the initial West Nile virus, I developed new neurological issues that were not present during initial infection. After 6 months of testing and no cause being found, Monday this week, my neurologist concluded that my new DX of partial epilepsy, spasticity, and MG-like symptoms, negative for antibodies, are due to reactivation of West Nile virus. Again, 5 years later and seemingly recovered. What are your thoughts on how new issues come about rather than just exacerbations of old symptoms?
Okay. You have a number of symptoms that are not typical of West Nile virus infection. Spasticity can occur, but that would be less likely a presenting symptom. With respect to your doctor concluding that you had reactivation, it's been 5 years since the initial diagnosis. The problem with that is that the IgM antibody, that is the antibody we use to confirm a diagnosis of West Nile virus infection, in some individuals can last, I think the record is now up to 8 years. And so the prevailing sentiment, and I think CDC would agree, is that you did not reactivate the virus. And even though the IgM, I will assume, was positive, and which is why your doctor said you had reactivation of the virus, the fact remains that it's unlikely. I had a case a few years ago where the IgM was checked, I think it was 6 or 7 years, and later after the acute illness, and I was told that what had happened is that in a minority of cases, the IgM can remain at detectable levels for years. So that's the way I would explain your symptoms. I would say if you have additional evidence, for example, if they actually did isolate the West Nile from your bloodstream, that would be very, very, very different. And that would present the first solid evidence that the virus actually may lie dormant, like the chickenpox virus. But without that type of isolation or duplication of the RNA found in the bloodstream, it's going to be very difficult to convince anyone that you actually have a reactivation of a virus that is almost, without exception, quickly eradicated from the body.
We have two other questions.
Go ahead.
Are you immune after your first infection, and are there other strains of West Nile virus?
Are you immune after West Nile virus infection? And the answer is yes. And probably there will be some cross-reactivity to the other strains. I know that there's probably about 4 or 5 different minor strains. I would think that if co-infection with those strains caused a problem like the dengue virus, where a co-infection with another strain can actually lead to more morbidity or mortality, that this would have been figured out in the almost 20 years it's been here in North America, and in the 30 or more years it's been there in Europe and Asia. And so I don't think that the additional variants of West Nile virus are going to cause any additional morbidity or mortality. I think that the IgG will probably cross-react to some degree, and so far I haven't come across any reports that suggest a co-infection or a subsequent infection with any different strains. I don't really know how different the strains are, but my thinking is that they're probably not so different. Okay. Oh, yeah, and let me go ahead and add one thing, okay? The fact that you're immune to West Nile virus infection, if you have the IgG antibody, does not at all imply that you're going to be immune to Zika virus just because they're kissing cousins, okay? You're not going to be immune to dengue. It's going to be interesting to see if dengue co-infection with West Nile does bring about some more severe consequences. But again, those consequences in the multiple strains of dengue are due to the immune response, an aberrant immune response. But no, you have to keep on putting on the DEET. You have to keep on putting on the mosquito repellent. You have to practice, good preventive measures. You also have to remember that West Nile virus is, for the most part, a preventable disease.
That's the final question.
Okay, the phone systems are down, or?
Wait, here's one more question.
Okay.
Among the very large group of West Nile support members on the internet who have had the illness, I'm sure many would gladly donate blood for others who have IVIG from this pool of high antibodies for other patients. Is this worth pursuing, or is it cumbersome to facilitate?
Wow, that's another great question. What? I've never seen you, and I like you already. Okay. So what he's talking about is actually when done early enough, would actually be a cure for West Nile virus infection. But here's the problem. You're not the one who's going to be getting 2,000 donors together and getting out the antibodies. And so what he's talking about is a concept known as passive immunity. So that if I have any infection and you give me someone else's antibodies that have been already formed against that infection, I will be cured. Those antibodies are going to do what they were programmed to do. They're going to destroy the invader. They're going to latch on. It's biochemistry. They're going to latch on, and they're going to destroy the invasion. And so we recognize even back in the late 1990s that passive immunity would work. The problem was and in fact, if we got the IVIG from Israel, or if we got it from some parts of Africa where West Nile virus has been endemic for decades, just by gathering it from the population, we might be able to have enough passive immunity to help victims. But I think your idea is noble. I don't think it's going to work because somewhere along the line, the people who have the knowledge are going to still have to separate out the immunoglobulins, and someone's going to have to go to their home and reinfuse the immunoglobulins and store and what have you, and that process is where presumably the cost becomes astronomical.
Somebody seems to have unmuted. If you have a question, you can go ahead and voice it now. We do have another question here. It says, what are the CDC's parameters for diagnosing a West Nile virus case?
That's a really good question also. I will tell you that I don't know the answer to that, not because they don't have classification schemes. So their classification of what I read to you about acute flaccid paralysis would probably not suffice as a case. It wouldn't meet the case definition of what they actually use to diagnose cases. And let me read to you what I mean, because this was a problem that was discovered in Houston, and I'm going to read to you from this page. One moment. This is actually from the group in Houston. Well, I'm sorry. Okay. So this is on page 4, and this is actually the group from Phoenix, Arizona. The bottom, I'm reading from the bottom of the page. Our case definition limited our ability to evaluate testing practices in WNV cases with less common or atypical presentations. For instance, across 6 institutions, we were aware of 2 patients who had CSF serological evidence of West Nile virus infection, but did not present with fever, so they were not included in the analysis. I think that quite frankly, in spite of the classification and the admittance that acute flaccid paralysis can present without fever or other viral prodrome, the reality, in my opinion and in my experience, is that the vast majority of those cases would not be counted, either by state health departments or even in CDC. If that's incorrect, I would certainly hope that someone would set the record straight.
More of a statement, but Sandy Johnson said, I'm Canadian and I have free coverage. Guinea pig with me. You prescribe, I will take. I'm tired of sitting and watching my body die.
Well, I'm pretty sure I'm not, I don't have any type of medical privileges in Canada. But, you know, yes. Although, you know, I was reminded that, you know, the Mississippi, the Mosquito Illness Alliance is actually trying to develop connections with other countries, individuals from different parts of the world, and those who have other viral infections. And so Sharon Sims and the rest of the group members would certainly welcome we could at least begin with open communication and then see what happens and develops from that point.
If the spinal fluid shows evidence of West Nile, does that mean it was neuroinvasive?
Yes. The question, if the spinal fluid shows evidence of West Nile antibodies, yes, it was neuroinvasive.
All right. We'd like to give you one last chance. If you have called in and you want to unmute the call, now's your opportunity. Or if there's anybody left in chat that would like to submit a question, we'll keep the lines open for just another minute.
Yeah, I'm going to go ahead and add this, one more thing about the spinal fluid. So obviously they did a spinal tap on you, and I would think that perhaps they found some immune cells in your spinal fluid. And so typically in this type of viral meningitis or encephalitis, we will see an elevated white count. It's usually lymphocytes, but early on it can be neutrophils and other types of white cells. But yes, if you have the antibodies in the spinal fluid, it implies that this is neuroinvasive. Okay, well, we have one question here from the audience.
Hello, Dr. Leis. You always do a good job. I enjoy listening to you. I have a question that I would like to ask. And the question that I think I heard, that if you're affected by West Nile, you could possibly cancer can come after that.
Oh, okay. No, I wouldn't say that. So what happens is that the West Nile is, okay, I'll repeat the question. The question was that if you have West Nile, can cancer come after that? What I've shown is a biochemical pathway. So you have West Nile virus infection, and you have not only a pro-inflammatory state, you also have a pro-tumorigenic state. And because there are some drugs, some molecules like the osteopontin, the OPN, irrespective of where it's actually formed, the fact that it's elevated makes it a more tumorigenic state. Now, that doesn't mean that you're going to develop cancer. There are so many unknown variables and multiple enzymatic pathways and biochemical pathways that have to play a role, plus the rest of your immune system. And so, right now, off the top of my head, were it not for the group at Mayo Clinic that thought they had a very strange case, and the group here at the University of Mississippi Medical Center that had an even stranger case, I got to tell you, I would never have, on my own, have thought about cancer and West Nile. But with the work of Dr. Bytes at University of Southern Mississippi, he's showing that there's increased osteopontin. And that increase was present in our members who were removed from the acute illness, sometimes by years. Actually, osteopontin is actually a target for cancer chemotherapy. So there are therapies that are being directed at trying to bring down or halt the production of osteopontin. Osteopontin makes the tumor more aggressive. It makes tumors that can spread more quickly. And it's been used as a marker of cancer for a number of years. And we just now, it was Dr. Bai who has made it clear that yes, it's elevated in these kinds.
Had West Nile 4 years ago and now battling cancer, what would be like a recommendation for me to
Well, I can't even, I can't even answer the question, and the reason is we actually have a survey out that is going to show whether or not there's any little increase in the year or 2 or 3 after West Nile virus infection. If we find no increase, then there's probably, I would say it's not related. You have to be very careful. I'm taking one, pathway and saying, yes, the biochemistry agrees. What I don't know, if there are two other pathways that are going to be opposing the effects of osteopontin. If there are, we don't know about them. But and eventually, yes, we should be able to get enough numbers through surveys whether or not there's a little blip in the rise of cancer after West Nile. We should be able to do that.
Thank you very much.
You're all very welcome again. Thank you for attending. And I guess the session's over. Okay. Do you have anybody else?
No, that's the
final
question.
Good.
Thank you, Dr. Leis. We're going to close out the call now, and the call will be online Monday for everybody that missed the call or you'd like to share it with somebody else. Thank you again.